Okay, so this is a work that I'm really excited about. So it's a new way to diagnose post-laser vision correction ectasia. We wanted to use the same word, so the same title of the CBI, and we called it CBI LVC, like laser vision correction. Same financial disclosure. And I want first to tell you a story. This is how we started. Pretty much everything started back in 2010. And we have been working with Corbis before that. But when really our work started, it was in a room of a hotel in 2010 in Chicago, in which we joined together and we decided that we wanted to be a group and to want to go to work all together. And we have to thank Oculus, because Oculus really helped us in this project. So I showed you a little bit of our journey. So we started with BIOP, then the normality values, the CBI, then the TBI, and then the stress strain. But now we have to move forward. We have to speak about the laser vision correction ectasia. So we do know that LVC is very accepted. But even if the safety profile is excellent, there are some cases that will develop ectasia. And the early detection is as important as it can be, because if you have a patient with good visual acuity and you do cross-linking, they will not progress. It is true, however, that there is no validated index to diagnose an early ectasia. And most of the time, what you do, and when you think that is an ectasia, you will see the patient back to see if it gets worse. But then you are accepting that this patient will get worse before making any decision. And ectatic change can happen many years after the surgery. Smile can cause ectasia, and also LASIK extra cause ectasia. So you're not safe with any procedure. You have to be sure. So obviously the first thing is do not harm your patient if you can. So try to be careful and not induce ectasia. But how can we use biomechanics to diagnose this? Well, we think that the primum movens, so the first hit of keratoconus, is a change in biomechanical properties, a focal change. So if it is the same in LVC, that could help. But there are many challenges. Well, the first one is you need to be able to separate normal patient from keratoconus. Then you need to separate stable patient from LVC and abnormal patient. But guess what? There is a problem, because the TBI and CBI are always abnormal in these patients, because the TBI and CBI are made to separate keratoconus and healthy patients. So how do you separate stable LVC from ectasia? You need a very large database. So then we called for help. We spoke with many friends around the world. You can see that there is India, that is Germany, there is Korea, Japan, United States, all over the world. We used the Corbis and we increased the database. This is the biggest database in history. We included, and now we'll show you in a second. Sorry, we had two aims. The first one was to create an index to separate stable LVC patient from LVC ectasia. And then we wanted to create a semi-automatic approach to even go further. But let's go that in detail in a few slides. Let's start with the first aim, to create the CBI LVC. We increased and we put 736 patients from different continents, many countries. They were stable patients after laser vision correction, PRK, LASIK, and SMILE, and ectasia cases post-LVC. Ectasia cases post-LVC are rare, but the patients we included were even more rare because they were not treated. None of them had cross-linking. And you can imagine that maybe getting 685 stable patients is easy, but getting 51 post-laser vision correction ectasia was really tough. So stable laser vision correction had at least 1 year of stability, and all laser vision correction ectasia were confirmed by 2 or 3 cornea experts, namely me, my father, and Renato Ambrosio. We used logistic regression, and we used 85 of the database as training and 20% of validation. Let me show you the result of CBI LVC. These are the variables, but I think we can skip them. I'm much more interested in showing you the results. So this is the ROC curve. Don't panic. The ROC curve it looks difficult, but it's not that difficult to learn. The higher is the curve, the better is the separation. But what you're interested is not in the training data set, because this index was created to separate as best as possible the training data set. What you're interested in is the validation one. And you can see there's a sensitivity and the specificity to separate stable laser vision correction from ectasia is more than 90%. But how does it work in clinical practice? Well, if the patient comes to your clinic, you need to know at least if the patient had refractive surgery. But sometimes this information is not available. Let's say that you have a patient that is old and doesn't know. Or maybe you have problems with language. They don't speak your language. So then we wanted to create a semi-automatic approach to help you even with this. But then there is another challenge, because as we say, all the indexes that are created, such as the BED, the CBI, the TBI, the KISA score, are abnormal after surgery. So then you need to separate normal from keratoconus, keratoconus from laser vision correction stable from ectasia. And then you have a bigger population. So we included 4,280 patients. Patients were enrolled in all these continents. And we had healthy controls, keratoconus, stable post-laser vision correction, and ectasia. The inclusion criteria were healthy patients, as you can see, no ocular surgery, no myopia, no concomitant or previous glaucoma or hypotonic therapies. And the Bellin-Ambrosio of less than 1.6. Keratoconus were clear keratoconus with no previous surgery, and stable laser vision correction were the same as before. We use the statistical analysis to do the same. So if you have an abnormal patient, or you think that is abnormal, we use the CBI to separate normal from everything else. Because what I told you before is that, if you remember, the CBI is abnormal also in laser vision correction. So it was a very good index to start. Then we created a second step that is called CBI step 2 to tell you, we think that this patient had laser vision correction. Can you confirm? And if that is the case, then you use the CBI LVC. But then let's go to clinical practice. I want to skip the statistical analysis. The sensitivity was very high in all of them. Just wanted to show you this. Sorry. This is using the CBI to separate normal patient from keratoconus and post-LVC. You can see that is more than 90% in training and validation dataset. Then you have the step 2, that is the one that will help you to tell you, we think that this patient had laser vision correction. And you can see that the sensitivity and specificity is very good. But you have to remember that this is not needed if you do know the diagnosis. So we need to see the clinical practice. Let me go further because it's much easier. Okay, so you can see from the right that this is a keratoconus. CBI is 0.99, BED is 10, TBI is 1. Very simple. And the Vinciguerra screening report will show you CBI, it is 0.99. Very simple case. If you're used to the curves, you're used to this. This is a stable LVC. This is what you get in the ARV. You get post-laser vision correction recognized. Please confirm. The patient had PRK, LASIK, SMILE. The patient had laser vision correction, but I don't know which surgery, or no laser vision correction. So do not worry if you do not know which surgery it is, because the CBI LVC works as good as. So if you click, what it happens is that you get the CBI LVC. The cutoff is 0.5 or 0.2. I think that 0.2 is better as a cutoff than 0.5, even if you will have a slightly more patient that will be positive, but I use 0.2. You can see that the BED and the TBI are grayed out. Why? Because post-LVC, you should not use this. CBI LVC, and you get the same in the Vinciguerra screening report. You get this warning, please confirm, and then you get the CBI LVC. This is an ectasia. You still get the warning. Warning. Tell me if this patient had surgery. You say yes. CBI LVC 0.91. Same thing in the Vinciguerra screening report, 0.91. So I want to stop, but I want to speak just one more second, and I want to explain you how important I think this is. It is the first time that we have an index that is able to separate stable laser vision correction from ectasia. With just an air puff, you do not need tomography. Obviously, I'm not telling you to bin your tomographer because you do need the tomographer, but the CBI LVC is just done with biomechanics. You do not need the pentagram, and is able to give you a sensitivity and specificity of more than 90% with just an air puff. Thank you.
Thank you.